Hey, it's Erin, your ear educator, and today we are going to review the BARD Dignishield rectal tube or fecal management system. So follow along. There's some great resources on the website, and I've included those in your Down to Right competencies, along with a tip sheet and videos. And there's also a tip sheet in the actual product itself. So if you were to open this to use on a patient, there is a tip sheet in the packaging too, which is super helpful. So we're going to look at the indications for the BARD Dignishield rectal tube, why we'd use it. We're going to look at the equipment and the setup. We're going to talk about insertion techniques, then I'll give you a few tips, and then maintenance and removal techniques. So let's look at indications and contraindications. So why would we use a rectal tube on a patient? Well, the biggest things are the fact that we want to either divert or collect any sort of liquid or semi-liquid stool. We really want to do this to minimize contact, especially in our bedridden patients with little to no bowel control. So patients with C. diff, or maybe they just have some other GI bug. Maybe these patients are unable to get up. Maybe they've fractured both of their legs. Maybe they're intubated. This is a great opportunity to put in a rectal tube so that we can minimize that skin contact with that stool, just to minimize skin breakdown. Another great option for this, and I use this a lot when I was at the University of Minnesota with our liver patients, you can actually infuse medication. So if you need to give an enema to somebody, especially like a lactulose enema. So if you've got an obtunded liver patient and maybe they haven't taken their lactulose in a while and they've got that buildup of ammonia, you can actually put in one of these rectal tubes and infuse that lactulose enema into it. And then while it starts working and doing its thing, then obviously these things will, the stool will be collected, and it's great. It's a great option if the patient is not really with it and they can't tolerate a regular enema. One thing to be mindful of is this is for adult use only. And then look at some contraindications. So you don't want to use this longer than 29 days. It will not work if the patient has, like, say they've got like a bowel obstruction or they've got stool impaction or something. It will not work if there's any sort of formed stool in there. The formed stool will actually push the rectal tube out, which is not a good thing. So it's really just for patients that have liquid or semi-liquid stool. All right. So then you want to make sure you don't use this on patients that are sensitive or allergic to any of the components within the system. We don't want to use it on patients that have had a lower large bowel resection or rectal surgery within the last year. We don't want to use it on patients with any rectal or anal injury, anyone who's had severe rectal or anal strictures or stenosis, or on any patient that can't tolerate the inflated cuff in the rectum itself, and we'll talk about why that's important in a little while. If a patient has a rectal or anal tumor, if they have severe hemorrhoids or fecal impaction. Like I said, if they've got fecal impaction, this thing isn't going to work. So you got to make sure that it's just your liquid stool or semi-liquid stool patients. We want to make sure that we're not using this on anyone who has got confirmed rectal mucosa impairment, so severe bronchitis, ischemic proctitis, or any sort of mucosal ulcerations. So you have to be really careful in your IBD patients as well. And then you want to make sure that we're not using this on patients with indwelling rectal or anal devices like a thermometer or any sort of delivery mechanism like a suppository, or anyone who has an enema in place. Like I said, this does allow you to infuse enema type liquids, and we'll talk about that in a little bit, but you don't want to use both, so pick one. So this is a great video. It actually walks through all the steps, and as you can see here underneath the cover, it has that tip sheet and it walks you through it. So click on this BD link or type it into your browser and then scroll down to the bottom of the page. At the bottom of the page, there's a PDF that has a tip sheet and it has the video. Highly recommend that you watch both of them. They're both super helpful. All right, so let's look at the equipment. So when you open up the Dignishield, the rectal tube, it comes in kind of like a similar setup like a Foley would. It comes in like this kind of container, plastic container, and it's got all the supplies in there. So let's kind of run through these things. So as you can see in the picture, number one is your drainage tube. That is going to kind of be connected to two separate ends. So the first end is the retention cuff. So number two, that's what secures the device into the rectum. Now you want to make sure that you actually get that up into the rectal vault, and we'll talk about that in a minute. And then the bottom part of that tube is actually what's going to go to the bag itself, number 8. So number 3 is the sample port. So just kind of like a Foley, you can get a stool sample. So maybe you're worried about C. diff, you can get a stool sample right out of the bag itself or the tube itself, which is where you want to get it, just like you would with the Foley. So you can get that. The nice thing too is number 4, you can see it's got a flushing port. So you can actually flush into the tube, instill some fluid, and you can remove it if you want to, or you can use it to flush. Number 5 is the piston valve connector. That connects to that brownish white kind of tube that's on top of the bag, which is number 8. And then you've got your inflation port, and we'll talk about that. You've got the collection bag. It does come with like a little odor neutralizer, so kind of like a little, whatever those little poo-poo things are you've got in the bathroom. It's kind of nice. It's got like a little odor eliminator. It's got your lubricated insertion syringe, so kind of similar to a Foley. And then it's got a 60 ml inflation syringe. So this is why you need to get that tube all the way up into the rectal vault. It needs to kind of sit in the rectal vault. You got to get it past the rectum. If you try and inflate that thing into the rectum, you can actually cause pretty significant mucosal damage. So you got to get that thing up into the rectal vault. And then you've got your tube clamp. So just like a Foley, if you need to, you can clamp it just to make sure you get yourself a little sample. All right, so when we're setting this thing up, first things first, take out all your equipment, and then you want to attach the drainage tube to the collection bag. So pull back on the green trigger switch just to engage that piston, and then connect it to the collection bag. Make sure that the green ring at the base of the collection bag is not visible. If it is, then you haven't set it up right. Then you want to put on the syringe, the 60 ml syringe, onto the inflation port, and then you want to draw air out, and you want to make sure that you have deflated the cuff. We don't want to pre-inflate the cuff. That's not best practice, but we definitely want to make sure that we completely deflate the cuff, and that will help you with insertion, because you're going to have to fold this cuff before you insert it. You kind of fold it into a triangle. And so you definitely want to make sure that everything is deflated before you do that. So make sure you attach your syringe to the inflation port and draw all the air out of it. And make sure that that thing just kind of sucks in on itself so you can deflate it properly. Next up, we want to attach the filled syringe to the green port, so the 45 ml green port. So fill the syringe with 45 mLs of tap water. It doesn't have to be sterile water. And then attach the syringe to the green insufflation port. Don't inflate it at this time, just attach it, kind of like we do with a Foley. Then you want to get your patient positioned. So it's good if the patient is on their left side, if you're right-handed. If you're left-handed, you would insert with your left, so put them on the other side. I'm right-handed, so I always just put the patient on the left side, put them in a knee-chest position, just like you would do for an enema. You want to maximize sphincter relaxation to kind of help with that catheter insertion. And then it's always a good idea just to do a little bit of a digital rectal exam to make sure that there's no fecal impaction, because if there is, you're not getting that tube in there. All right, so this is probably the most important part, I think. But you want to make sure that you grab the cuff of the rectal tube, and you want to make sure it's fully deflated. So again, make sure all the air is removed. Then the first thing you want to do is kind of squeeze it and flatten the cuff. Hold the flattened cuff at the upper green corners, and then you want to fold it into a little triangle. So fold it at kind of a 45-degree angle, and then fold it into a little triangle. Now, after you've got it into the little triangle, then you want to lubricate it. So it's a good idea to kind of generously apply the lubricating jelly to the sphincter area, and you really want to lubricate the end of that green tube really, really well. You can put some at the end of the catheter as well, because you're going to have to get it up pretty far, but really make sure that you fold that. If you don't fold it into a triangle, and the triangle helps with insertion, if you don't fold it into a triangle, you are going to have a hard time trying to get that thing up there. So fold it over into a triangle, and that kind of point on the triangle will help with insertion, and it's easier to grab onto when you're inserting. So next up, you're going to insert the cuff. In my personal experience, I have found that it really helps to kind of, wherever you've got the triangle folded, you keep like your pointer finger on there. I've also found that it's helpful that you keep your pointer finger there during insertion, because you really kind of got to get that cuff all the way up into the rectal vault. You can kind of see in the picture on the left here, if you just insert that thing into the rectum, like I said, it will cause mucosal damage of the rectum, and you don't want to put extra pressure on that. You want to get it up into kind of that hole, that space, that hole space above the rectum. That's your rectal vault. So I think it's a good idea, and this is what I've done in the past, use your index finger to hold the triangle, and then you want to insert that all the way up until, like, if you think about where your index finger meets your hand, you want to get that kind of all the way up there. You want to make sure that that gets up into the rectal vault. So as the cuff passes into the patient, kind of slide your thumb away from the cuff so you're not holding it as much, but just use your index finger to hold on to that and then push it all the way up into the rectal vault. Once it's inside the rectal vault, it will naturally open and it'll kind of seat itself. And then this is when you want to inflate it. So you want to inflate the cuff with that 45 mLs of tap water, and then make sure that the inflation port remains parallel to the catheter to prevent kinking or any sort of blockage or blockage of the injected fluid. So just make sure it's nice and straight. When you inflate it, as water is injected into the inflation port, the cuff will inflate into the rectal vault, and again, it should seat itself. Reposition the cuff, and if it's not working or you're getting fluid coming back on you, reposition the cuff and then try and reinflate it. So again, just kind of gently pull on that, just make sure it's seated well. We want to make sure that it's sitting against the rectal floor and not actually in the rectum. We want that up into the rectal vault. Just make sure that the device is high enough again and actually in the rectal vault again. We don't want it to slide out of the patient, and we don't want to cause any trauma to the rectum. So make sure it's in the right spot. So I'll just run through some maintenance and removal things for you. So in terms of maintenance, so if you have to do some cuff irrigation, you certainly can. It will instill fluid in there, but you can fill the syringe with tap water and attach it to the irrigation port, and you can infuse water by depressing the plunger, and then you can actually observe the flow of fluid coming down into the catheter tubing. So let's say the patient is making maybe some harder stools. You can use this to irrigate and hopefully try and get rid of that blockage. If there is leaking around the cuff, though, you may need to reposition and reinsert and then reinflate. Sometimes the balloon, if it's left in long enough, it will deflate. So you just want to make sure that it's staying inflated. And like I said, if you see leaking, you might need to reposition and reinflate. If you want a stool sample, you want to try and get it through the tubing just like we do on a Foley. We want to uncap the white sample port and then gently kink the catheter between the piston valve and the sample port. And then you want to insert your slip tip syringe into the sample port and draw up your appropriate sample, which is really nice because then you don't have to worry about, spilling anywhere, and it's coming directly from the patient. If you have to flush the tubing, if the catheter tubing becomes obstructed with fecal matter, attach your flush syringe to the purple flush port, and it says flush right on it. And depress the plunger, and then make sure the flush port remains parallel so it doesn't get kinked off. If you have to replace the bag, say it fills up, say you've got like a C. diff patient or a diarrhea patient or something like that, you can change the bag while still leaving the line in place. So if that's the case, you want to grab the piston connector and pull back on the switch until the piston ejects from the collection bag. Once it's removed, you can dispose of that and then just replace it with a new collection bag. And then let's say the patient is getting better or you are at the point where you need to remove this thing. You're going to again attach that depressed syringe into the green inflation port and then withdraw all the water. It should be about 45 mLs. And once the cuff is deflated, you're going to grasp the catheter as close to the patient as possible and slowly slide it out, and then dispose of the device according to protocol. So just some tips for use, just like anything else with any other line, tube, or drain, just question whether it's still indicated each shift. And if it's not, if the patient doesn't need it, remove it, just like a Foley or any other tube or intubation tube or whatever. Always make sure you're documenting your eyes, nose. Make sure that you're doing a good skin assessment of the perineal area. And then ensure the catheter isn't kinked, twisted, or externally compressed. And then just like a Foley, you want to hang the drainage bag low and below the rectum. And then change the drainage bag routinely to prevent odor, and it will fill up fairly quickly, especially if you have a diarrhea patient. So just make sure that you are changing it often. So as you can see here, this is the reference for the Dignishield on the website. It's also on the Donna Wright competency form. So check that out. It's got some really great resources. And if you have any questions, let me know.